Many husband and wife, many couples are planning to conceive, but they don't find conception very easy. They find it difficult to conceive. I actually refrain from using a term called as infertility. I use infertility or a conception delay in such cases. But what I have found in the last 20 years of my practice of infertility is that most of the people do not know what time of cycle they need to have an intercourse, or they need to have a sexual intercourse to have pregnancy. So in today's video, I'll tell you which are the fertile days of the cycle, on which days there is a maximum chance of pregnancy, and whether these days they differ in a natural non-medicated cycle, and what are the difference in a medicated cycles with clomiphene, letrozole or a HMG. Good morning, I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. Before telling you about which days of cycles to have intercourse on, let us have a basic understanding of a menstrual and a ovulatory cycle. There are two different cycles which are simultaneously going on in a female's body. One is a uterine cycle and one is a ovarian cycle. These two are correlated. Let me come to the menstrual cycle first. The first 4 days or 5 days is the menstrual phase. Then there is a proliferative phase. After proliferative phase comes a secretory phase. Then these are correlated with the ovarian cycle. In ovarian cycle, the first phase is a follicular phase till the ovulatory phase. This follicular phase is powered by a follicle stimulating hormone. This hormone increases the growth of the follicles. This follicle basically secrete the estrogen in the body, and this estrogen basically increase the endometrium of the uterine wall or of the uterus, and that is why it is called as a proliferative phase. It leads to the proliferation of the endometrium. Then there is an ovulatory phase which is about 24 to 48 hours. This ovulatory phase is because the increase in the estrogen level leads to the increase in the endometrium, and that increase in estrogen level leads to a positive feedback to the LH, and LH increases causes the ovulation. Immediately post ovulation, the follicle ruptures, it becomes corpus luteum, it starts producing progesterone in a high quantity compared to the estrogen, and that progesterone acts on the endometrium and it leads to the secretory changes in the endometrium, and that secretory changes are basically for the embryo to implant. And if the embryo does not implant, after 7 days after the ovulation, the estrogen and progesterone level decrease and they cause a withdrawal bleeding. So in a regular menstruating female, in a regular cycling female of 28 to 30 days, from day 1 the follicle starts increasing. By the day 10, day 9, day 10, the follicle reaches to a size of about 10 to 12 millimeter, and follicle increases at the rate of 1 to 2 millimeter per day. By about 14th or 15th day, the follicle reaches the ovulatory size of about 18 to 20 millimeter, and it ruptures on any day between day 14 to day 16 or day 18. For couple to have pregnancy, they should be having sexual intercourse starting day 9 or day 10. If it is a 28 or 29 day cycle, then we say they need to have intercourse starting from day 10. If it is a 26 or a 25 day cycle, what I tell people to have intercourse on day 8. What I tell, the conventional wisdom what we were taught is to have an alternate day sexual intercourse starting day 10 till day 20. But what I advise to my patients is, if for a 28-30 day cycle, start having sexual intercourse from day 10, have sexual intercourse on 2 consecutive days, day 10 and day 11, have a gap of day 12, again have 2 consecutive days of sexual intercourse on day 13 and day 14, have a gap on day 15, again have sexual intercourse on day 16, day 17, have a gap on day 18, again have sexual intercourse on day 19 and day 20. I always advise my patients to have sexual intercourse on these 8 days. There is a scientific logic why to have this 2 days sexual intercourse, 2 continuous days followed by a 1 day gap, then again have 2 days again followed by a 1 day gap. The logic is, the egg, when you are not doing a follicle monitoring, when you are trying at home, whenever the ovulation occurs, the egg can be live for 16 to 24 hours only. So that is why you should not have a gap of more than 24 hours between the intercourse. So there should not be a 2 day gap. The second logic is, the sperm can survive in the vagina, basically whenever there is an intercourse, the sperm separates from the seminal fluids and it goes inside the uterine cavity. Some go inside the uterine cavity, and most of the sperm is stored in the cervical crypts, and they keep getting released slowly in spots, and that is why the more sexual intercourse occurs, the sperm gets stored, and as a result, that sperms can be stored for about 48 hours. Research have been found that they can be stored for about 72 to 96 hours also, but minimum 48 hours they are stored in the cervical crypts. And so if the couple have a relation today and the ovulation occurs tomorrow, and they for some reason cannot keep or have not kept sexual relations, then the sperm which was ejaculated today, that will help in the fertilization of the egg which is released. Now I advise my patients not to have sexual intercourse for more than 2 days consecutively, because most of the males find continuous, if they are having sexual intercourse daily, then with every further day the ejaculation volume decreases, and maybe by third or fourth day it is very difficult to ejaculate, and that is why it is important to have a rest of 1 day. The main purpose of a sexual intercourse is the semen gets deposited into the vagina. If you are doing sexual intercourse and there is an ejaculation, or there is a difficulty in ejaculation, or there is a very then there is no point of doing sexual intercourse for conception. And that is why I don't advise people to do sexual intercourse more than 2 days when they are trying at home. There should be a 2 days sexual intercourse starting day 10, followed by a 1 day gap, again have continuous 2 days of sexual intercourse followed by a 1 day gap, and this is from day 10 to day 20. After day 20, there are very minimal chances that sexual intercourse would lead to pregnancy, and same is case with before day 10, then there are very minimal chances that sexual intercourse would lead to pregnancy. But if female has a 25-day cycle, 25-day cycle means that she will have an around ovulation around day 10 or day 11. Now the conventional wisdom says that ideally a female should be having sexual intercourse for up to 4 to 5 days before the day of ovulation, and 1 or maximum 2 days after the day of ovulation, because sometimes there are multiple follicles which ovulate and not all the follicles rupture at the same time. Some may rupture today, some may rupture 12 hours later, some may rupture 24 hours later. So the logic of having sexual intercourse is about 6 to 8 days in a cycle, 4 to 5 days before ovulation and 1 to 2 days after ovulation. So if a 25 female who is having a 25-26 day cycle, she would be ovulating around day 10, day 11. So they should start having intercourse from day 7, day 8 onwards. And that is the logic when I tell my patients of 25-26 day cycle, you start having intercourse on day 8, day 9, have a gap of day 10. Now what is day 8, day 9? The first day of the cycle. Many people have got this misconception. They count the last day of the period as first day. The first day when the period comes, when the menses comes, it has to be counted on fingers as day 1. And from that day 1, you have to include that day 1. Suppose the period occurs today on 21st of March, then 21st, 22nd, 23rd, 24th, 25th, 26th, 27th, 28th. 28 would be the day 8. And then you have to have sexual intercourse on day 8, day 9, have a gap of day 10, then again 2 days intercourse with a 1 day gap. If for some reason, whatever days I have told, the 2 consecutive days are not possible, either husband is not well, wife is not well, or for some social or for some other reason they are not able to have intercourse, then if suppose instead of 2 days you are able to keep only on 1 day, then keep for another 2 days continuously, have a 1 day gap. There is no hard and fast rule that this should be done. Now why these 10 days are important? Because 97 to 98% of females would have an ovulation in this specific window, and that is why this period is called as a fertile period. Along with that, most of the females should check their cervical mucus. Cervical mucus is the thing which God makes. These cervical glands are made for a reason. These cervical glands, they basically secrete a watery liquid, and this watery liquid is under the function of an estrogen. The moment estrogen follicle reaches pre-ovulatory levels around 10, 11, 12 millimeter, there is a thin, copious, watery cervical mucus. And the main purpose of that cervical mucus is that the sperm can flow through the cervical mucus and reach up the endometrial cavity. This cervical mucus, it remains thin, watery and copious for about 4 to 5 days till ovulation, and just 10 hours, 8 to 10 hours after ovulation, because the progesterone starts increasing, the thickness of the cervical mucus starts increasing. It, instead of becoming thin, watery and copious, it becomes slightly thick and creamier. The more thicker and the more creamier the cervical mucus becomes, the passage of sperm through the cervical mucus decreases, and as a result, that is why I tell that the chances of pregnancy or a conception decrease if you have sexual intercourse after 14 to 16 hours of ovulation. And so that along with the days, the female should also look for the cervical mucus. Some females start complaining to me that I am getting watery discharge and that is why I am not able to conceive, I tell them this watery discharge is good. God has made this a very important discharge so that the sperms can flow. There is a biomechanics and biochemistry involved. This cervical mucus has got various micelles, and in normal cervical mucus, these micelles are lying at various crisscross pattern. They block the passage of sperms under the influence of estrogen. When the estrogen reaches to a level of 250 picogram per ml, these micelles lie parallel and sperms can travel within those parallel micelles and reach up the cavity. Many people think that they should have sexual intercourse around periods for pregnancy. That is a totally false notion. Many people think that having sexual intercourse just before periods, it induces the periods, while that is not scientifically correct. The only thing is, it may be a coincidental finding. They may have done sexual intercourse at the time of when the hormones are withdrawing, and the period would automatically have come if they had not a sexual intercourse, maybe a couple of days later. Hopefully this solves the very important question whenever you are trying to conceive naturally at home, on which days to have a sexual intercourse. Now, when the couple have tried at home, they have not succeeded, then they come to us doctors and we start giving them medicines for ovulation induction. The main purpose of ovulation induction is in anovulatory females, in females who are having irregular cycles, we make the follicles with the medicines. Either we give clomiphene citrate or we give letrozole. Normally we start clomiphene citrate or letrozole from day 2 or day 3 of cycle. Clomiphene citrate is given 50 mg from day 3 to day 7 or day 2 to day 6 or day 1 to day 5, or it can be given on any day from day 1 to day 5 starting, and it has to be given for 5 days. Letrozole, what we were told, it has to be started from day 3 to day 7 of the cycle. But in last very many years, after multiple patients and multiple studies, I have found that there should not be a fixed day of starting a letrozole. Just like clomiphene citrate, it can be started on day 1 as well, and many studies right now are saying that we can start letrozole from day 1 as well. Now the moment, because the mechanism of action of letrozole and clomiphene, as I have discussed in my previous videos, are different. Clomiphene basically occupies the estrogen receptor. It is an estrogen agonist and a partial antagonist also. So it gives a false sense to the hypothalamus that there is a less in the amount of estrogen, and as a result it gives a negative feedback to the hypothalamus, the pituitary hypothalamus axis. It produces more amount of FSH and LH, and this FSH and LH leads to the increase in the number of follicles. And that increase in a normal cycle, the follicle ovulates at about day 14, day 15, while in a clomiphene cycle, the follicle reaches the ovulatory size around about couple of days early, and the size is roughly the same, about 20-22 millimeter. So in a clomiphene cycle, whenever we are inducing a clomiphene cycle, the sexual intercourse has to start relatively couple of days early. So if I am giving clomiphene, the sexual intercourse has to start from day 8, day 9 of a cycle, compared to the day 10 of the cycle, in which there is a no ovulation induction. Letrozole is aromatase inhibitor. When I am starting letrozole, the rise, it inhibits the conversion of testosterone to estrogen, and as a result it increases FSH, but the increase in FSH is relatively slow, it is not very high. So as a result, clomiphene might cause multifollicular ovulation, but letrozole usually in 2.5 mg doses causes a single follicle ovulation. The rate of the growth of follicle is slow, and follicle reaches the ovulatory size at about day 13, day 14, which is similar to a natural cycle. And that is why in a letrozole cycle, the sexual intercourse for sexual conception should be almost around the same as day 10, starting from day 10. When we give gonadotropins, these gonadotropins can be given alone, or they can be given combined with clomiphene or letrozole. When we give gonadotropins alone, the follicle ovulates. The ovulation size of a follicle is about 16 to 17 millimeter. Because the gonadotropins increase the number of follicles relatively early. Again, like clomiphene, the sexual intercourse has to start relatively early, day 8, day 9, day kind of thing. But if we are giving clomiphene after letrozole, or after gonadotropin after letrozole or after clomiphene citrate, then we start sexual intercourse at about the same time at day 9, day 10. So the main logic is, you have to, if you are doing a follicle monitoring of a patient, then you have to see the cervical mucus also. If cervical mucus is not visible on ultrasound or on past speculum examination, then the chances of patient conceiving naturally would be very, very less, because cervical mucus is the medium through which the sperms go and that cervical mucus is relatively decreased or less in clomiphene patients compared to letrozole or gonadotropin patients. There are various methods to increase cervical mucus. The most important method is to increase the hydration, to take the increase in liquid of the for the patient. So this was a small, very important video. Most of the people do not know on which days of the cycle to have sexual intercourse. But this, in females who are having PCOD, who are having irregular periods, there is no fixed day. You have to go for ovulation induction followed by follicular monitoring to know the days of on which to have a sexual intercourse on. I hope you like the video. I request to subscribe to our channel, to share the video, and to comment on the video. Thank you. Bye bye.